So I'm going to give a 2-minute introduction. So this will be largely focused on adults, but everyone is welcome to stay. So I'm not Shobha. Shobha's over here. I'm one of the adult metabolic physicians at Queen Square, and there is a saying in medicine that if you want something practical, you need to ask a nurse, not a doctor. So the next 2 talks are going to be given by our lovely nurses, one from the uroneurology team at Queen Square, and one from the gastroenterology, the bowel team at UCLH. So we work together, and some of you I recognize, and some of you will have met people from this team already. So we're going to start with Shobha, who's going to tell us about the bladder, and then we'll have Shaila telling us about the bowel. I think it will be fairly rapid, but we hope there'll be time for questions afterwards. Both of them are going to stay through lunch, so you are welcome to approach either of them or me through lunch if you wish, because I think we're probably running a bit behind. So, Shobha.
Good afternoon, everyone. My name is Shobha. I'm one of the uroneurology nurse advisors at National Hospital for Neurology and Neurosurgery, part of UCLH Trust. Thank you so much for the invite, and I really feel humbled to be here and present a very important topic about bladder dysfunction in ALD and AMN. So, going on to the slides straight away because we are really short of time with this. So the bladder dysfunction is unfortunately a very common dysfunction in both men and women. It presents as the overactive bladder, which can be urinary urgency, frequency of urination, nocturia, and incontinence, which are the most common symptoms. Stress urinary incontinence, which is the involuntary leakage of urine on effort or on any exertion, like sneezing or coughing, laughing, bending over, and things like that. And also very low stream of urine in both women and men, which can significantly impact on the quality of life, but very frequently, which is underreported and also undertreated. So just a little diagram here to show the severity of bladder symptoms in AMN. 67% of patients reported symptoms to be of moderate or severe grade and having a significant impact on the activities of their life or the quality of life. Despite this high figure, only a third of patients receive appropriate treatment for managing the bladder symptoms. So when you see a specialist for your bladder symptoms, what happens during the assessment? You'll be asked a few questions about your bladder symptoms, how it is affecting you, like frequency, how many times do you pass urine, how many times do you wake up at night? It really is very important for you to make a little note of all these things. We might be kind of overseeing these things thinking, oh, it's just me. I just go to the loo every few hours or maybe a couple of times in an hour. So do make a little note and keep a diary of visits to the toilet. Test the urine for infection if you think you have any symptoms of urinary tract infection. See if the bladder is emptying after the urination. You would feel like you are not emptying it fully, and also you feel like there is some more urine left in the bladder, although you've been to the toilet just a few minutes ago. And this can also be looked at by doing a bladder scan. Urodynamics, which is one of the studies we do in the clinics to understand the dynamics of your bladder and the urinary tract. And also during the assessment, there will be a little talk about the treatment options. So this is just a little picture to show you how the bladder scanner looks like. I'm sure some of you would be familiar with this. I do recognize some faces I see in my department. So you know how it looks like. That's a little picture to show the post-void residual, which is nothing but what is left in your bladder after you have passed urine. So the symptoms can be in two different types. One is the storage symptom and the other one is the voiding symptom. In the storage symptom, what we mainly look at is the urgency, frequency, nighttime waking up, nocturia, and incontinence of urine. That's because the bladder is not able to hold on to that urine or getting those signals when it shouldn't be getting to keep contracting, So in the voiding symptoms, we mainly look at the hesitancy. You sit on the toilet but you can't pee. You have to wait for some time or strain. So straining, interrupted stream, stop, start, that kind of a stream. And also, most of the patients will be experiencing double voiding. You pass urine and then you stand up and you feel like going again. So you sit back again, or you stand and bend over and do some jiggling and things like that to make sure you have emptied your bladder. So looking at the treatment options, first of all, I'm not going too deep into how the nervous system kind of controls your bladder and everything. My colleague Shaila will be looking into some of those. So lifestyle modification comes as the first one. So we recommend fluid intake of 1 to 2 liters a day, although this should be individualized depending on your condition and the amount of fluids you are allowed. So looking at the drinks that can irritate the bladder, so very important thing is the caffeine. Caffeinated tea and coffees, green teas, hot chocolate, fizzy drinks, especially the cola, caffeinated energy drinks and fresh acidic drinks, mainly freshly squeezed orange juice. These are the things which can irritate the bladder. And the drinks that don't irritate the bladder are the opposite, like decaffeinated tea and coffee, water, all types of diluted fruit juices, non-acidic fresh drinks, herbal teas, and red bush tea. So reduction of caffeine to below 100 milligrams per day reduces the overactive bladder symptoms. So just for an example, a single espresso is equivalent to 60 milligrams of caffeine. There is also something called as the radar key scheme. I'm sure some of you will be aware of that. If not, there is a little picture there which can be ordered from the radar key company, and it's available on Amazon as well for a small price. So the next thing will be the bladder training, which is nothing but training yourself to voluntarily hold on and try to hold on for increasingly longer period of time. So you begin with small delays. When you have the sensation to pass urine, it says such as 30 minutes, but I always talk to my patients and I know it is not easy to even hold for a minute or 30 seconds. So I always say just count back from 10 to 0 backwards and see if you can hold on for that period of time, and then keep increasing from 20 to 0 and things like that. So just a little exercise. It will be a great achievement if our patients would be able to hold on for 30 minutes and then gradually work your way up to urinating every 3 to 4 hours. So pelvic floor muscle exercises. I've put a little QR code there. If you have the QR code reader, you can just scan the QR code. It will take you through to some of the exercises which are demonstrated and explained by our pelvic floor physiotherapist, Natalia Vasquez, from the uroneurology department. It's very informative and very simply explained. I hope that will be very useful for you. So it is to mainly help strengthen your pelvic floor muscles and urinary sphincter. So these strengthened muscles can help you stop the bladder's involuntary contractions. So definitely a physiotherapy referral would help with the bladder symptoms. So there's a little YouTube QR code there. Can I move on to the next slide if anyone needs to scan still? Okay. Okay. So the next will be the medications. After you've tried all the conservative management, we move on to the medications that relaxes the bladder. First group will be the anti-muscarinics, example tolterodone. I'm skipping the oxybutynin because we don't prescribe those anymore because of the cognitive impairment it causes. Trospium, solifenacin, darifenacin, fesoterodone. So these are the medications generally the patients are prescribed with to help to relax the bladder. Possible side effects are dry eyes, dry mouth, and constipation. And the next one is the marabegron. And again, the possible side effects are hypertension and palpitations. So if someone is already hypertensive, to be careful prescribing this. So we do offer different treatment options like percutaneous tibial nerve stimulation to relax the bladder. It's a treatment option for overactive bladder, mainly for frequency, urgency, nocturia, and incontinence. A nerve in the leg called the posterior tibial nerve is stimulated near the ankle. So I've got a little machine here. So we use, can you hear me still? Okay? Yeah. So we use this machine and we use 2 needles we place at the ankle and we stimulate the nerve. This treatment is given for 12 weeks every week for half an hour, and it modulates the nerve that controls the bladder function. And there is not many major safety concerns reported with this treatment, and almost 60 to 80% of patients report benefit from this treatment. And we have a huge patient group refer to us, and we see almost 25 to 28 patients per day. That's like 2 clinics run per week. So you can imagine how popular it is. It's really good. So it's just another picture to show you how the treatment takes place. The patient sitting and relaxing with a book. And the next option is the botulinum toxin injection, injected into the bladder. So it's directly injected into the detrusor muscle under cystoscopic guidance. And it appears to be a very highly promising treatment for intractable detrusor overactivity, like overactivity of the bladder with most of our neurogenic patients. It just takes under 15 minutes mostly if there is no complications, and done under local anesthetics. And the discomfort score is about 3.4, between 0.5 to 9, so it's quite on the lower side, you can imagine. And the effect usually lasts between 9 to 13 months. And with the Botox, patients often need to self-catheterize. So we make sure that we teach our patients how to self-catheterize before they go on this treatment. And it does significantly improve the symptoms of frequency, urgency, and nocturia, and also the quality of life. Fewer urinary tract infections reported with this treatment, and also reduced urethral leakage when somebody is using an indwelling catheter, like we call it as catheter bypassing. It reduces that as well. So when it comes to how to manage difficulties in emptying the bladder, so we were talking all about frequency, urgency, nocturia, incontinence, but some patients can also experience retention of urine. So how do we manage that? So complete bladder emptying is important for avoiding recurrent urinary tract infections and also maintaining the renal function. There are no effective medications for improving voiding, so catheterization is usually the best option. I've laid out quite a few options of catheters on the table here. There are quite a lot of options available for both male and female users. So I'll leave them out on the table there for you to have a look. Thank you. So, not going very deep into the catheterization because you can catch up with me later because there's just 1 minute left. So, different types of catheters again, positions and accessories available to hold, to catheterize. Containment products, there are quite a few available like the pads and sheaths for men. Different options of pads available according to the leakage and the general use. Sheaths, which is like a condom which fits over the penis and can be connected to the drainage bag or alternatively to a valve. So I've put out a few sheets on the table as well for you to have a look later. So suitability of indwelling catheter for someone who cannot manage self-intermittent catheterization or anything else. So there are options of male and female catheterization urethral and then suprapubic catheter. So just a few pictures of the catheter bags and the valves available. Different products like the urinals and Shavy, the mirrors to help with catheterization, key cards and keys. Our responsibility with the continence, just a little slide there. Useful websites for your information about the Continence Foundation and Radar Key and Age UK, World Toilet. So urine infections, very quickly capturing this, urine should not be routinely checked unless there are symptoms suggesting infection. Antibiotics should be limited to symptomatic urinary tract infections. Unrestricted use of prophylactic antibiotics can lead to drug resistance, as we are aware. However, in individuals with proven record of recurrent urinary tract infections, it is sometimes reasonable to start the prophylactic low-dose antibiotics. But this decision should be taken along with the specialist urology team. There are other supplements like the cranberry extracts and D-mannose that may be helpful to prevent infections because of E. coli. Just a little recap again. Bladder dysfunction is frequent in ALD, AMN. Check to see if the bladder is emptying or not with the bladder scan. Treatment options, again, fluids, exercise, tablets, medication, electrical stimulation of the nerves and Botox. Get in touch with the primary care community continence team. Get a referral through your GP. There are quite a lot of options, and also our department, uroneurology, here to help. And we are located at National Hospital for Neurology and Neurosurgery, Queen Square. Thank you. Any questions?
Thank you. We're going to move on to the bowel section of the presentation real quickly. We're getting short on time, but I'll pass it along, and then if you have any questions, we'll do a combined quick bowel and bladder question session while I show Slido, and they'll also be around during lunch if you have questions, and you'll have a bit more of an opportunity to look at any of the items they brought if that's of interest. Okay, thank you.
Hello everyone, thank you for this opportunity. Let's just dive in. Having so many of you in this room, it's completely overwhelming and understands and explains the magnitude of the bowel symptoms. So what we're going to cover today is all of these things, what's supposed to be, but we're just going to breeze through. Anyone in particular wants anything in particular to be elaborated? We have to make this interactive. Okay, I'll just breeze through with everything. For this, I really want for you all to read through this because these are the experiences that patients walk through into my clinic, where it also explains why we do continence care and why we have events like this where we can have an opportunity to talk about it, because it's something that we don't talk much about it as well. So when we talk about the pelvic floor organs, this is for both men and women. I do have my little bit, sorry, I don't have male ones because they don't give it to us. So with the pelvic floor, it starts from the front and it ends with the back. It's like a hammock. Inside the hammock, you have the bowel. So as you can imagine, very close to the nerve at the back end. Then you have, for the men, it will be the prostate. For women, it's the uterus. And then we have the bladder. So all three of them sit in a hammock. With one is affected, the other two also are going to be affected. So this is where they all sit. As you can see, for the female, because of the reproduction, it's much wider. Some of the conditions that we see in our clinic is constipation, fecal incontinence, sexual dysfunctions, and the symptoms arising because of the constipation is very common: hemorrhoids, prolapse, fissures, and all of these conditions, the bottom line is their quality of life is impaired. This again in a very normal defecation dynamics. So if you think this is our bowel, we have the rectum and we have the anus. The rectal muscle is an involuntary muscle. We have no control on it. The anal muscle is a voluntary muscle. We have control. So when the rectum is full, it sends a signal to the brain to say, okay, I'm full, I need to go. If it is socially acceptable, then we go sit in a position which then allows the rectum and the anus, both of them, to relax, and the stool comes out. With certain conditions and medical conditions, the signaling becomes disconnected. This is where we either end up with conditions like constipation in a very broader term, or fecal incontinence, where we cannot relax the muscle, the voluntary muscle at the bottom end, or the voluntary muscle is completely relaxed, which then makes the feces or the stools to come out when we are not in control. The ideal position to sit, this is the picture that I really want, okay, I can't say that. This is a picture I really want you to focus, how we nearly have to sit in the toilet. Anatomically, the rectum and the anus, they both have to align in a certain angle. So a squat position is a very normal position which aligns both of them. In Western toilets, we cannot have a squat position. So the best ideal position is get a stool, elevate your feet if you can to get a posture so that you can align, and anatomically we are able to go to the toilet. So for coming to the bowel incontinence, as I explained, when we have any symptoms or any injuries or pathological reasons with the anal muscle, this is where, when the muscle is not closed, is where we end up having fecal incontinence. And how we assess fecal incontinence is trouble. Sometimes it can overlap with the constipation as well. If you're completely bunged up, right up, only the residual feces comes out. But that can think as a diarrhea, so it is very important to understand, is it a fecal loading and causing diarrhea, or is it diarrhea itself? Mind-gut axis is something we talk a lot about in our neurogastro clinic. It's very important because as we think the nervous system is like a trigger, is a direct connection. You have a good connection, if you're talking to each other, everything is fine. When there is a disruption in the connection is where things can go wrong. So I really have to rush. So another important topic we talk about is the sexual dysfunctions. The common sexual dysfunctions that can be related with the bowel symptoms and neurological conditions is a decreased libido, ejaculatory dysfunctions, painful sex, impaired sensations, hormonal changes, fatigue, impaired, and pelvic floor spasm. And how do we manage with all this? First of all, we allow to have an open conversation about it. And I think one of the speaker also mentioned in the previous talk, we might not be as aware as you are about your condition. So help us and empower us to have that conversation with you, to open up and to understand your condition better. So it's very important that you give us a consent to talk about the sexual dysfunctions. And the very common thing I normally ask in the clinic is your partner aware that you have these symptoms? If there is a very simple symptoms as for in painful sex, where we have the very conservative, or what we call as a first line management, is we do the sexual counseling. We use something called a Yes lubricant, which is a water-based lubricant. It is available over the counter as well and in pharmacies. We help them about using very simple sex toys to stimulate stimulate the functioning of the nervous system. We assess the body image. How is it all affecting them? Because body image is another big thing in neurological problems or neurological conditions. It becomes extremely challenging to have it in a very normal position. So we help them in superficial way how we can achieve pelvic floor down training and up training. It's both. As you can see, I do the pelvic floor. When I treat, it's everything for me, the bladder, bowel, pelvic floor in the organs. So we either do the up training where your muscles are very loose, we help you to do the up training, and when the muscles are extremely tight, we help you to do the down training. Again, this is all depends what you need is based on the assessment. So I have to do a digital rectal examination or a pervaginal examination for me to understand where we stand. And if it is further investigations or further assessment is needed, we then do the referral to the sexual health clinics. And I really want you all to focus on what we call as the power of touch. And if nothing kind of like works, we encourage them with the power, even if it means just a simple cuddling, holding hands. That's the beginning. I'll just breeze through this because I think my colleague Shobha has covered. It's a very similar investigations that we do as well in the bowel clinic. The one where you can see with the balloon is we have the rectum and we use an anorectal biofeedback catheter, inflate this with, inflate this with air. I have just 1 minute left. Inflate this with air and then we look for the rectal sensations. What's my role? We've already covered with the bladder thing, more or less the same thing. In very specific, we also do the mindfulness where we call as a body scan. And we have the irrigation system, but I am around, so come and talk to me and I can show you around what irrigation is, which also comes in the specialist biofeedback, where we kind of help to use water to help to stimulate the bowel so that you can empty it. But it also needs a good dexterity assessment, but we also have home support to enable that facility to help with the irrigation. I think I've just breezed through it, but you know what, do I have at least like few seconds left? Okay, do you have any questions? I think I'll go with that first. Yes, sir.
Maybe what we might do is move this table and Shobha and Shaila out at lunch to the area there for coffee, so people kind of lunch, they kind of agree to stay until the end of lunch and stuff.
Thank you for the presentation. It's a topic of great interest to me for obvious reasons and because of the AMN that I have. I got interested a few years ago in the mechanics of the intestine and how they work. And I came across by accident through my previous professional life, a paper from the Institute of Mechanical Engineers. Let me repeat that, the Institute of Mechanical Engineers, addressing this whole issue of bowel management. And what it revealed was that the intestine and the bowel are simply a tube. Is simply a tube going in one direction, and food waste and fecal matter gets transported down the tube. And it was pointing out that there's a mechanics involved in all of that. And it set my mind thinking about well, is anybody doing anything on that? And I discovered 2 institutions in the UK who are working on this precise problem of how to introduce possibly mechanical devices controlled by, an external electrical device, a phone or whatever, that could help squeeze the intestine, squeeze the bowel at the right point, and relax it at another point. Do you know of any? That's a long-winded question. I'm sorry about that. But do you know of any research that really is going to introduce some far-sighted innovation in terms of bowel management? Because it's a problem that I think could be alleviated by having good technology at play here.
Very interesting, and you're right, there is so much out there, but the only thing is it's still not funded by the NHS. There is St. Mark's Hospital, which is trialing something called MOWOOT. It's called MOWOOT. Can you all hear me? It's called a MOWOOT, which is like a band, okay? You put it around you, and when you put it, it's like a tennis ball. It improves or squeezes the peristaltic by stimulating it, and you wear the belt for 20 minutes and you feel that stimulation. So what it does, it artificially creates what is called a peristaltic movement. So if we were to like anatomically look, we have the right side of the bowel, we have the transverse, and we have the left, and then it goes down into the sigmoid, and then it goes into the rectum. And when we have problems, we always look where the loading is, where is your discomfort, and it is all based on that is where we do the assessment. And yes, MOWOOT is coming up, but it's still not funded by the NHS. The trial is going on, but we do have very high hopes on MOWOOT band, yeah. I'm not promoting, I've got nothing to do with it, I just know it's trialing out.
Okay, as we said, we'll move all of this outside so that you guys have the opportunity to take a look at some of the nice things that they brought. I think it was very interesting. It was great to hear both of your presentations. And I think, it's nice that you have some interactive things as well. So I think that'll be good for you guys to see. And they will be out there if you have any other questions. Unfortunately, we do need to move on to the next presentations, but thank you so much. Yeah.
Thank you to you too as well.
Thank you.